Hello, everybody. It's so good to be here. We had a little bit of a technical issue earlier, so that's why I'm on a little bit later. And for those of you that might be new to Re+active, we are a physical therapy clinic, and our mission is to help people with neurologic diagnoses recover movement, strength, and confidence through brain-changing therapy and exercise. And we do this with one-on-one sessions of physical therapy. We also have occupational therapy, psychology, and personal training. We also do group exercise classes. And finally, we do a lot of education for healthcare providers who treat some of the unique diagnoses that we see at our clinic. And you can learn more about us at reactivept.com. And if you want some more educational resources, if you're a provider, you can go to reactiveeducation.com. And normally Julie does the Facebook Lives, but I thought I would start by introducing myself a little bit since I'm filling in for her today. And I might be a new face for some of you, and some of you I might also know. But my name is Brittany Kim, and I am a physical therapist at Re+active. I graduated from USC in 2015, and then I did the orthopedic residency program at USC right after I graduated. And during my time in the program, I was also part of an interdisciplinary pain team, and we treated primarily CRPS. And that is probably one of my most favorite diagnoses to treat. And the reason why I like it so much is that it's this combination of ortho meets neuro. And that's another reason why I really love working at Re+active, is just because I do get to see a mix of both. And currently I specialize in treating those who have connective tissue disorders, centralized pain, complex orthopedic conditions, and orthopedic conditions in the neurologic patient population. So today we're going to go over one of my favorite articles of all time, which is this lovely blend of neuro meets ortho. And when I first read it, it completely blew my mind. And it has definitely changed how I look at classic orthopedic problems, and has definitely made me fall more in love with the brain, for sure. So here we go. We're going to get started with the article. And the article that we're going to go over today is called Feeling Stiffness in the Back, a Protective Perceptual Inference in Chronic Back Pain. And this article is by Stanton et al. In 2017. And I just want to start by kind of asking how many of us have experienced this kind of situation. So, and I definitely have experienced this kind of situation myself, where someone comes into the clinic and they are saying that they have a lot of stiffness or issues maybe in their neck. And then when you go to evaluate them, you know, you're expecting to see some sort of like hypomobility or flexibility deficit, possibly some like myofascial restrictions, and then you're just kind of coming up empty. And I feel like that's just kind of a weird situation to be in, because someone is saying and telling you, I have a lot of stiffness, but you as the clinician are not finding any objective measures. And I know that when I was a new grad, that when I first experienced this, I kind of like was second guessing my manual skills and my ability to evaluate and interpret those findings. And, you know, I kind of felt like something was wrong with me and like understanding what was going on. But now I've learned a little bit more. The other awkward part of this conversation is someone is telling you they're experiencing something in their body. They're saying, I have stiffness. And it's kind of weird to be like, but you're not stiff, right? It's kind of like you're gaslighting them, and that just doesn't feel right. You're not validating what their experience is, but then how do you reconcile the fact that they feel something that you yourself are not observing clinically? And so I think this article is going to be really helpful. I think it's going to help us do better as clinicians in understanding what's going on, but then also how to help educate and treat our patients. So let's dive into the study. Okay, so the study, the number of subjects they had 15 people with chronic low back pain who also reported feelings of back stiffness. And then they had 15 age and gender matched healthy controls, and they did not have back pain or stiffness. And what they did, so like the whole setup for everything, they had them lie prone, and then they used this probe that applied a certain amount of force. And the probe could also detect the displacement of the force to understand someone's mechanical stiffness. So I'm going to share my screen for a second. Hopefully this works. And I just want to show you an example of what this looks like. So this actually comes from the article online, and it's a free access article, which is fantastic. So here's a video of what they actually did. So they had this probe, and then they pushed down and came back up. And I don't know if you guys heard the sound on that, but we're going to get to that in a moment. So the probe pushed down, kind of like when we do a PA, and then determined the amount of displacement from start to finish. And that was determined to be the objective stiffness. So the mechanical stiffness of the spine. I'm going to stop sharing my screen. Okay, so they did that. And then their first question was, is there a difference in objective stiffness between the two groups? And then the other kind of question that they had was, does that relate to their perceived stiffness? So they had the subjects also rate their stiffness feeling on a scale of 0 to 100, 0 being not stiff at all to 100 most stiff imaginable. And what they found is that there was no difference in objective stiffness between the groups. So what does this mean, right? This means that the subjective feeling of stiffness in the spine does not relate to the biomechanical properties of the spine. And I think that this is just like mind-blowing, right? It's so interesting that in both groups, they had similar levels of stiffness, and they have different feelings of stiffness in their low back when the probe is applied, but there's no difference between the groups. So this is really interesting because it's kind of like pain, right? But now we're taking a whole nother sensory perception, which is stiffness, and we're exploring this a little bit more. Now, this study just goes deeper and deeper and deeper into just many different levels. So we're going to go into the next part. So, okay, there is clearly a sensory perception part. So they decided we want to know more about that. So the next question they asked is, what is the ability of someone with chronic low back pain to detect changes in force, and how much force is and how much force is actually being applied versus the actual amount? So with this setup, they had the participant in the same kind of position, and they were told you'll receive an application of force, and they were asked to tell the examiner how much force was exerted. And they did a little training procedure to do this, and it was anywhere from 50 to 70 newtons of force. So they had to identify whether how much force was being applied to their low back. Then they were also asked to identify if the force application was the same or different than another application of force. So this was labeled as force discrimination threshold. So is force A the same or different than force B when applied? So they had to figure that out. And what they found is that people with chronic low back pain and stiffness tended to overestimate the amount of force applied, but they were better at detecting changes in force compared to healthy controls. And also the increased feelings of back stiffness was correlated with greater force overestimation error, which is really fascinating. So they were overestimating how much force was being pushed on their back, but they were really, really good at determining whether there was a difference between the force levels compared to healthy controls. So let's put this all together. So we have the biomechanical measures of the back do not relate to someone's actual perceived feelings of stiffness. These subjects all had the same biomechanical stiffness level, but they had different feelings of stiffness. So what we're seeing here is that stiffness is therefore a perceptual construct. It's something that the brain has to figure out and calculate to understand what is going on. The researchers also said that this is evidence that this is a protective strategy, basically, for the body to have stiffness. And this is evidenced by the fact that in the second part of the study, that basically the back or the brain is overestimating the force applied. And I would say on purpose, right? And I think this makes a lot of sense. This is a really great strategy because if force equals bad, then it is creating a wider definition of what bad means. So, it might be a little force, but it's going to say it's a big force because that's a little bit more alarming. And therefore, we need to protect the back from damage because a big force could damage us. And so it's going to overestimate the input. So then that way it can create a safer environment for the back. Additionally, with what they found was that they had a really great ability to discriminate a change in the force applied, which then tells us that when someone is feeling that little change in that force, this person may also be experiencing a protective effect, because that's also a great strategy, right? If we can micro sense these little changes and protect ourselves from any change from happening at all, then maybe we'll be safe. It's kind of what I think the back and the brain are trying to figure out together in this situation. Okay, I mean, already in the article, I think that that's pretty amazing stuff, but they didn't even stop there, and they took it a step further, and this is where it gets even more mind-blowing in my opinion. So they identified that stiffness is perceptual, right? Versus purely biomechanical. And then they thought, well, if this is true, then with any sensory perception, it can be modulated with another sensory input. And this is the part that's just like so crazy in this article. So let's see what happens. They chose to do an auditory input as the thing that would modulate the stiffness feelings in this person's low back. So in the next part of the study, what they did is they set everything up the same. The probe was exerting a force, but what was a little bit different is they kept the force the same. So it was constant at 60 newtons. And the variable that they were playing with was the sound that they used. So I'm going to show you some examples, but within this part of the study, there's kind of like two little mini studies that happen. So the first part is they compared the force estimation error. So they delivered a force and asked the person how much force was applied. And then they basically calculated what the error was in relation to what they said. So 60 newtons of force, maybe they say 70, and they find the error there. And then what they did is they did it in 3 different conditions. So they did no sound, a creaky sound that sounds like a creaking door. And they chose this because it might be the most closely related to what feelings of stiffness might be like. So an example might be, I have creaky joints. So they added the creaky sound. And then the other was a whoosh sound, and they called this the control sound. So what I'm going to do is I'm going to show you the creaky sound. And I just want to warn you that this video, the sound is not pleasant. So here we go. I'm going to share my screen. And we're going to watch the creaky sound, and then I'm going to show you the whoosh sound. Okay, so I think you should be able to hear, and be prepared volume-wise. Okay, so that was the creaky sound. And then now what I'm going to do is I'm going to show you the whoosh sound that they had. So here we go. I'm going to play the whoosh sound. Okay, so in the study, what they did is 3 repetitions with no sound, 3 repetitions with the whoosh sound, and then 3 repetitions with the creaky sound. And so now I'm going to show you what the results were, because it's super interesting. So here are the results. This is figure 2, I apologize, in the study. The black columns are those with chronic low back pain. The white columns are those who are in the control group. What they found is that oh, I'm so sorry. Hold on, this is the wrong figure. This figure is the one I should have showed you earlier about when they did the force estimation error versus the force discrimination. So let's just review this really quick, but we know that people with chronic low back pain overestimate, and then the people compared to controls. And then they also were really much better at discriminating the force threshold. So let me show you now the correct one. So let me share my screen again. Okay, this part is the cool part. So hold on one second. Not like that wasn't cool, but this is just really cool. Okay, so we're going to go over this part of the graph first. So we have no sound, control sound, and creaky sound. And with the no sound, they did 3 repetitions. And I thought that's kind of interesting that over time it kind of, their force estimation error was less. And maybe that makes sense because things are being applied over time. Then the control sound, interestingly enough, they underestimated. And I kind of wonder about that. And then it kind of like evened out in the end. And then finally, with the creaky sound, it got significantly worse in the direction of overestimating the force. So when they added the creaky sound and they repeated it 3 times, the person, and actually both groups, but more so the group with chronic low back pain, overestimated the amount of force being applied to them, which is super interesting. Okay, so I'm gonna pause my share here for a second. And we're gonna talk now about the next part of the sound. And while that might sound like really cool and crazy all on its own, get ready because there's a whole nother auditory thing that they add. So in part 2 of the auditory thing, what they did is they decided to use sound again, but they did it in a different way. So the variable this time was volume with the creaky sound. So it was the creaky sound the whole time, but there were 2 instances. So there was creaky sound that was just the constant volume, and then there was creaky sound with a decreasing volume over 3 trials. The force was still 60 newtons the entire time. So let's see what happened, because this is the really, really super cool part. So let me go to the correct image, and then we're gonna change it so you can see this part of the graph. Okay, so on the left here, we can see that there is the same thing we saw in that first graph, right? So creaky sounds constant, and the stiffness error was that they were overestimating the amount of force. Okay, then for the creaky decrease, what they did is they played the sound and then they made it a little softer, and then they made it softer still, right? So it's high, medium, low volume. And as you can see, they went from having an overestimation of force to being more accurate to actually having an underestimation of force, which is so interesting that that could happen with just an auditory input. And what's crazy about that is the force amount was the same every time, yet they were able to modulate the participant's ability to perceive the level of force. And as they turn down the volume of the creaky sound, they also turn down the volume level, right, of the force perceived. And the person ended up underestimating the amount of force, which is so interesting, right? Okay, so that was a lot. That was a lot to learn. And I want to first maybe summarize what we learned before we get into how can we maybe clinically apply this, because I hope you, like me, were just having all these ideas about how we could apply this concept into our treatments with patients. So today we learned that someone's feeling of stiffness does not relate to biomechanical stiffness. Also, biomechanical stiffness is the same across people in this study, whether they had back pain or not. And what I do want to point out is this is a small sample size. So this was only a total of 30 people. I think in my mind, it would be nice to know, maybe dig a little more into the literature, or if possible, have a larger study where there's more people to understand, is there any relationship to biomechanical stiffness and pain? I would not be surprised if there was no relationship, because we also know that that happens with pain. There's no real relationship between tissue damage and having pain. So I wouldn't be surprised if stiffness was the same. So, and then what we also learned was that people with chronic low back pain overestimate the force applied, but that it can actually be modulated. And what we mean by that is the volume level can be turned up or down through the use of modulating sound, so some sort of auditory input. We also learned that people with chronic low back pain have a really good ability to detect a change in force. And this is important because it talks and it speaks to the sensitivity that we can be developing in our nervous systems, right? And then altogether, I think what this says is that stiffness is perceptual and protective. And I think what we learned today is you cannot escape the brain, right? If the person is sharing with you that you are or that they are concerned about a bodily feeling that they're experiencing, like stiffness, the brain is part of that picture, and it's trying to do the work to process that sensory information. And we ought to think about how, it's processing sensory information, but then there's all these other parts of our brain that connect that sensory input to other pieces of our being. So someone may say, I'm feeling so stiff, I'm worried, right? I'm worried that I'm so stiff. That's a feeling, that's an emotion that we have. And it's brought on by the fact that we're experiencing something physical in our body. And it's very reasonable to have that feeling that comes with it. And you probably have all heard this, right? Some people might say, oh, well, I'm just getting old and that's why I'm stiff. And that's a cognitive belief. That's a belief that as I age, my body breaks down and therefore that's why I'm stiff. But what we've learned today is that stiffness is perceptual, which means it could be changed, it could be treated, and we can retrain the brain to help us perceive those feelings, to help us be kind of not always in a state of protection, right? And now what do we do with this information moving forward? So if you have someone where their physical exam is not really matching up stiffness wise, then you may need to shift your mindset to what is the brain's role in the situation, and think about what you can do about it. So a big hint is, if this is a sensory perception processing issue, maybe you should treat it, right? So maybe you train it. And the other piece to think about is, where does that even occur in the body? And that's the brain. So we have to retrain the brain, retrain the sensory perception of what the body is experiencing and the brain is experiencing. And we do have a really fabulous sensory mapping cheat sheet in our free download section on reactiveeducation.com. I would highly recommend checking that out. It was put together based on a series of articles. One of those articles was by Adrian Lowe's group, where they studied, I think it was a very small case series of people with frozen shoulder, and they did sensory training and mirror therapy, and they saw a lot of gains with that. And then a lot of the protocol developed from that came from a low back study, a small case series, where they did pretty intensive sensory training, and the people had improved pain and function with that as well. So basically, the protocol is put in this lovely little cheat sheet that is easy to use, and I just highly recommend it. It makes things so much simpler, and it gives you a path and a map to use on how to where to go next. Then I want to ask if I could kind of play devil's advocate for a moment. What if someone does present with mechanical stiffness that you can identify with your objective exam? Because I mean, I think we've all seen that, right? We've had people who come in and they are just really, really, really stiff, and you can feel the stiffness there. And I think the question that I would ask, or what we should ask of ourselves, is, I guess, how does that relate, right? How does it relate to their goals? How does that relate to their pain problem or their functional issue, right? And then most of all, how does that relate to their perceived level of stiffness? Because I've definitely seen people who don't feel like their back is stiff and don't have pain, but their back is crazy stiff, right? But then it's like, do I need to treat that? And maybe I do, and maybe I don't. And so we have to understand, what does it mean to that patient? And how can we help them understand what's going on? How much of it is maybe mechanical? How much of it is maybe brain related? And then what's that overlap potentially between them? And we know that stiffness, now we know stiffness is perceptual. And so then you have to think, well, how does the potential mechanical stiffness play a role in their perception of stiffness? And maybe if you just got them moving better, their perception would also improve, because there's less likely of that feeling of stiffness because they have more mobility. So they're interrelated is what I would say, but we have to know that you cannot take the brain out of it, right? The brain is processing that information. And then finally, my challenge for you today would be, we know stiffness is perceptual and it can be modified by other sensory modalities. So what other sensory modalities can you pair with your interventions to make them more effective in reducing stiffness? And if you want, you can put your ideas in the comments section below. But yeah, I mean, I just have so many ideas that you can think of, right? Like maybe you're even using noise canceling headphones, maybe you're using actual sounds like in the study. What could you use? Maybe like sense of smell. What could you use for sight? What could you use? I mean, just so many different ideas that you can think of. And what if you could use that as a way of enhancing and changing that volume knob? You'd be so much more efficient and effective in your treatment if you can take into account that there may be a processing issue, and then how can you drive your treatments to accommodate that? Okay, so thank you so much for joining me today, and thank you for being patient with me with my technical issues. And you know, if you really like this kind of information, I highly recommend that you subscribe to our newsletter. You can go to reactiveeducation.com to do that. What you will get with that are these types of videos, so you don't have to come here every week. You'll get emailed the videos, and we also include resources. So I'll be including a link to this article and also a link to the sensory training cheat sheets. And when you sign up, you get all these other resources too that we have. So we always like to help people learn more and have access to great resources and some of the newest literature out there. And finally, if you found this content valuable, share it with anyone else that you would like so that they can learn a little bit more and maybe up their practice level as well. So again, thank you so much for joining me today, and I will hopefully speak to you soon.